afternoon. My name is Julie Burns, and I am the President and CEO of the RIZE Massachusetts Foundation. On behalf of RIZE and our presenting partner, the Kraft Center for Community Health, welcome to today's virtual learning community, Harm Reduction, Housing, Hope. Before we get started, a few announcements. All participants will be on mute throughout the program, and the webinar is being recorded. The slides and the recording will be posted on our website after the event. We're also live tweeting. Our handles and hashtags will be in the chat box. Please join the conversation. Although today's event is just an hour and there's a lot to cover, we'll have a few minutes for Q&A at the end. Questions can be directed to the presenters during our discussion by using the Q&A option on the toolbar. But what I really want to make clear right from the outset is that this is our first webinar on this topic, but it won't be our last. The incredible response for this convening confirms that there is interest from all across the treatment ecosystem to learn, share, and collaborate. You'll receive a short survey at the conclusion of today's event. Please take a minute to fill it out and help us plan for follow-on events. There are so many amazing things happening here. We want to lift up and bring forward best practices and want to hear from you about the best way to continue today's conversation. We're humbled that you took time out of your busy schedules to be with us today, and some of you are new to RIZE, so just a bit of background. Launched in 2017, RIZE is a statewide nonprofit foundation created to end the overdose epidemic. We're made up of a constantly growing group of providers, payers, unions, advocates, and people with lived experience who are equity-minded, entrepreneurial, collaborative, and dogged in pursuit of our mission. We share and convey a sense of urgency that addressing the overdose crisis can't wait. One of our core strategies is to serve as a neutral convener, bring people together, share learnings, support exploration, enable change. And that's our goal for today. Here in Boston, given the recent attention on the encampment at Mass and Cass, we know that housing must be part of any solution. But it can't just be any housing. It needs to have the right therapeutic mix of safe spaces, clinical care, and recovery programming to be successful. And harm reduction needs to be part of that mix. Engaging in harm reduction while in stable, supportive housing can make the difference for many people experiencing addiction. The recent attention to Mass and Cass also laid bare the deep stigma about and misunderstanding of addiction. And that's why we wanted to have this discussion. I don't have to tell you, it's not the people that are broken, it's the broken policies and systems that have landed us here. And we're going to need a paradigm shift to move forward. So what might a mutual goal of safe housing, increased harm reduction, and a sense of hope look like? Well, that's the focus of today. I'm thrilled to be joined by Emma Roberts and Sarah Gorry of the National Harm Reduction Coalition, an organization that is an international leader on harm reduction education. It's been such an honor planning this event with them, and I know their presentation is going to be amazing. Before I hand things over to Emma and Sarah, I'd like to thank everyone for joining us today. We had just about 400 people register for this event, from the harm reduction and housing professions, from government, from healthcare, you name it. And that shows not just a willingness to learn, but a desire to create change. That alone gives me hope that by being here, seeking to change the status quo, we're all looking for a better path forward and that together we'll be successful. Emma and Sarah, welcome. We look forward to today's presentation.
Thank you, Julie. We're so grateful and honored to be asked to collaborate on the work that RIZE and the Kraft Center are doing in Massachusetts. I know before COVID, was able to travel to Massachusetts to do some training and technical assistance with folks there. And I'm sad that we can't be with you in person, but so glad that we can continue this in a virtual setting. And to that end, I know there was a question in the chat about whether we could enable closed captions. So I'm just going to give a second for our colleagues that are doing a wonderful job behind the scenes with tech to see if that is a possibility today. I know it's being recorded, so people would get that recording afterwards. But before I jump into my content, is that a possibility? It's being worked on. Thank you. Yeah, so if we want to move to the next slide, and whilst they're working on that, I can just do a brief introduction. So as Julie said, my name's Emma Roberts. I'm the Senior Director of National capacity building here at National Harm Reduction Coalition. My experience in harm reduction started in the mid-90s in the UK when we saw an increase in heroin use there, and we responded by enabling the establishment of syringe service programs back then. I was working in a community centre and we started one in the corner office. So I've been around for a while, and I'm really excited to be here because I know many of the providers on this call are also mobile providers working out in the field, which is what a lot of my experience has been. I ran a mobile syringe service program here in New York City where I'm based, but I've also done capacity building and training for a long time. So I'm so grateful to be now full-time at the National Harm Reduction Coalition and work with folks across the country who are trying to expand harm reduction interventions, you know, including housing first, and then also like syringe service programming and naloxone access. And so I'll let Sarah, my esteemed colleague, who's bringing some wonderful experience in housing and harm reduction today, introduce herself in a moment. But if we could move to the next slide. I'll just tell you a bit more about the National Harm Reduction Coalition. We recently adopted a North Star statement that says we create spaces for dialogue and action that help heal the harms caused by racialized drug policies. And again, wonderful to be invited into this space to begin conversations with you about how to change things and heal harms and affect systems that we're all working within to try and support the participants and clients that we work with. The Harm Reduction Coalition was established in the early 90s in response to then what was the AIDS epidemic. And it was led by a group of people who use drugs and their allies to address the needs of people at that time. And we've grown over the years to work in, you know, a range of areas across the country. We work in policy and advocacy from the federal level right down to state and local levels. We provide training and technical assistance, like the type of work that we're doing here today. We also host national and regional conferences, and I hope that many of you might be able to consider joining us in Puerto Rico in October of next year in 2022. We were supposed to do it in 2020, and of course, COVID, we couldn't. And our partners in Puerto Rico, who were so excited about having us finally be able to come to the island, were like, please don't go virtual, please come and see us in person. So we've been having a series of events, and if you sign up on our website at harmreduction.org, you'll get access to those ongoing events to keep people engaged over this time period. But we will be hosting, fingers crossed, toes crossed, everything crossed, an in-person event in October of next year. And it's at a wonderful space to be in if you're wanting to really learn more about the spectrum of harm reduction opportunities and possibilities that are out there. And then we also have a key focus on overdose prevention, given, you know, as Julie said in the introduction, what we're seeing in the country. You know, we saw these figures recently come from the CDC about, you know, the last 12-month reporting period. We saw over 100,000 deaths from overdose, and we believe that overdose is, you know, preventable. So a lot of our work and our medical director, Dr. Kim Soo, who's amazing, has been focused around, you know, getting access to naloxone, increasing overdose prevention programming, also getting, you know, better access to medications for opioid use disorder and other treatment, you know, for people, and access to health, because it's not just opioids that are causing overdose, especially with fentanyl entering the drug supply in recent years, right? We're seeing that show up in a range of drug supplies. So we have a lot of work around that. And then if you go to, again, to our website at harmreduction.org, we have a range of resources and publications and online trainings that, you know, you can access, and you can always reach out to myself and the team at Harm Reduction Coalition if you want any follow-up support or questions after today's session. Next slide. So today's contents, it's just a brief overview. Because the audience got really diverse, because there was such a lot of interest in this, we're going to cover a little bit about housing and housing first. And for some of you, you may be, you know, that may be familiar to you, and some of you may be newer to it. So as Julie said again, like, this is just the beginning of this conversation. So we're going to set off by just, you know, Sarah's going to walk you through an overview of that. I'm going to take you through a harm reduction overview again. Some of you may be familiar with this, some of this may be an introduction for some of you. And then Sarah's going to talk a little bit more about the kinds of partnerships that we can really begin to think about in terms of housing first and harm reduction programming to kind of, you know, really support us in engaging the folks that we're working with who use drugs, especially those that are unhoused. So yeah, next slide, we'll jump into that. So I'm going to hand it to Sarah to introduce herself and also give you that initial overview around Housing First.
Thanks, Emma. Hi, everyone. My name is Sarah, and I'm coming to this work through a few years of experience working out in Buffalo doing street outreach. And I worked in Housing First in a few different programs over the years, and really appreciate and love the interconnections between Housing First and harm reduction, and the ways that partnerships can be developed between the two communities and the work that we do. So Housing First, it's a proven approach, and it really is. It challenges the traditional treatment first approach that used to exist within housing programming. And Housing First really comes from the perspective that if a person is living without housing, that the solution to that is housing. And so it's a strategy of connecting people with permanent housing quickly, with few to no treatment preconditions, behavioral contingencies, or other barriers that have historically made access to housing incredibly difficult. And Housing First really comes out of the work from Dr. Sam Simbaris out of New York City in the 1990s, and his team with Pathways to Housing really provide a lot of research and a body of evidence showing the efficacy and creating the evidence-based for Housing First. You see it becoming adopted by HUD in like 2014, 2015. And having worked in street outreach at the time and not really being aware of all the intricacies and the policy developments behind it, it really felt like magic. There was a time before Housing First was really widely implemented where people that I knew who were living outside didn't have access to housing. There was long waiting lists, there was incredible barriers, and housing was very not an option for the majority of people. And then when Housing First really was adopted, all of a sudden people had access to housing in a way that they hadn't before. So if you go to the next slide, the U.S. Interagency Council on Homelessness put out these core elements of Housing First, and they really are a checklist that they recommend for communities to look at and see if they how they're implementing Housing First in their communities, and outline the elements of Housing First and how it might look or should look. And so I know there's a lot of text on the slide, but every bullet point was so important, and wanted to include all of them because Housing First is incredibly dynamic, and it's a beautiful model to follow. But there's some highlighted areas that really show how it overlaps with harm reduction approaches and engaging with people and who use drugs in that way. So the first bullet point, with access to programs not being contingent on sobriety, it's incredibly important to provide housing to people who use drugs, and Housing First really allows for this to happen. And housing services and goals are highly tenant driven. So this means that tenants have a lease and tenant rights and choice in where they live, what their apartment looks like, what neighborhood they live in. And the service goals are really, you start to see in this model, and this is where it really diverges with the treatment first approach model, but really housing gets peeled away from the supportive services that are offered, and housing is the constant, and really everything else with the engagement and problem solving approach versus meeting therapeutic goals. Really the housing is a given, and the rest is opportunity, choices, and options that tenants in Housing First programs can be offered and pursued and explored together. You can go to the next slide. And so this bullet point especially really calls to attention how Housing First is informed by a harm reduction philosophy, and this recognition that people who are tenants in a Housing First program, that drug use is part of it, and that addiction are part of some people's lives. And our role as housing providers to engage tenants in a non-judgmental communication regarding drug use and alcohol use, and providing support and engagement around risk reduction and safer practices that Emma is going to speak to in the next section of some strategies to do this. And really one of the most beautiful aspects of Housing First is the flexibility embedded into the model, especially regarding how, when, or if a tenant pays rent. And really this last bullet point, in Buffalo, we made it a specific intention to embed within our systems of Housing First that eviction back into homelessness is avoided at all costs. And really, it's important to recognize as a housing program, it's your opportunity and your role to work alongside a person, and understanding that access into housing is life-saving. And so you can go to the next slide. So we wanted to include some opportunities. There's probably many on the call, and so I encourage you to find who's doing housing work in your community. And if you don't know, there's this link at HUD.gov where you can click on find homeless resources near me and find out who's coordinating housing services in your community. And we're going to talk about some specifics here. We try to keep it really broad and understand that these are models that communities then tailored to what their needs are. So it may look a little differently in your community than how we're describing today and what examples we provide. But and also it's important to note that rural communities, your housing program coordination may not be happening within your own county. And so looking regionally who's doing this work and who you can partner with across your county is important as well. And it's important to talk about Housing First's limitations. It's not a new model, and the evidence base is there, but it still experiences aspects of not in my backyard, within communities of. It's really misunderstood in some ways, and there are some community-based organizations that within communities that might disagree with the approach, or and it really echoes in some ways in parallel to some of what we hear in the harm reduction world of providing access in this way to housing in such a low threshold model must enable something, or we hear a lot of that language in the housing world. And so it's really important to know that part of Housing First might be educating your community on the approach and the elements of it, and reminding us that like harm reduction, Housing First is also an evidence-based approach. One of the biggest barriers and limitations to Housing First is a lack of affordable housing. It's really a key component to Housing First being implemented in communities. If you can't find a landlord that'll rent to you with a fair market value rent apartment, access to housing just isn't there. And so there are a lot of factors that impact housing placements and referrals, but it's important that communities invest in affordable housing and invest in housing programs that are following Housing First models and approaches. You can go to the next slide. So I really enjoy reading through this publication. The authors did an analysis on the literature that exists that looks at the partnership or the collaboration between Housing First and harm reduction. And what they found was often a lot of the research done really considers harm reduction or looks at harm reduction as being compatible with Housing First rather than critical to. And the authors really call attention to the fact that harm reduction is embedded within to Housing First, and it's a crucial component of the model and of the intervention. And you can go to the next slide, and I think Emma will talk to us about some harm reduction approaches.
Thanks, Sarah. Yeah, so I'm going to kind of walk you through a brief overview of what we're talking about in harm reduction. And as I say, some of you will be familiar with this and it may be a refresher, and for some of you it'll be an introduction. And so we can move to the next slide. So when we're talking about an approach, you know, again, alongside Housing First, harm reduction is evidence-based. It's been researched the heck out of. We've got, you know, at least 8 federally funded research projects that point to this being a successful approach in terms of engaging people who use drugs, and helping them to reduce the negative consequences, not just around drug use, but other risk behaviors such as sexual health and sex work for folks. So, and it's this spectrum, right? So and many people also, when I first came to it, you know, when there was that similar kind of response to what Sarah was saying, like, oh, you're enabling people, right? You're not for abstinence then. And I'm like, no. Abstinence is a really important part of our spectrum of interventions. But what we're saying is that we're also including safer techniques for people. You know, people come to us, they might not be ready to make big changes yet, but they want to be safer, right? They want to improve their health. So we engage people with interventions like safer drug use, sterile syringes, safer smoking or safer snorting kits, all these kind of different materials that can help people use in a safer way, or educating them about safer injection or how to set up their injection equipment in the most hygienic way, even if they are unhoused, right? There's ways that people can adopt, you know, little things that will improve and reduce their risks. And then we move along the spectrum to managed use. So some people, again, might not be ready to fully stop, but they want to make a change. They want to manage their use. They want to use less, or they want to use in a way that's less chaotic. I often, for myself as a practitioner, would think about it's like I'm moving people from chaos to stability. That stability looks different to different people. And then along the spectrum is abstinence, right? Many of the people that I've worked with wanted to be abstinent, especially from the problematic substance. So again, abstinence can look different for different people, and that can be abstinence from any and all drugs, or it can be abstinence from the substance that is problematic for them, and they would manage other substances in a way that, you know, is not problematic, you know, doesn't interrupt their stability. And when I'm talking to substance use treatment providers, who I often feel like you know, some really worried, like, well, so I'm just supposed to throw out everything I've done for the last 20 years. And I'm like, no, keep the skills and the tools that you've been using for some people some of the time. I'm offering you more tools in your toolkit so that you can help more people more of the time. And also, especially if you're working with people in abstinence who then relapse, right, and may need harm reduction techniques to keep them safe until they can make a decision about what they're going to do with their recovery pathway. And I was speaking to a substance use treatment provider before COVID up in Austin. We were doing some trainings in upstate New York, and she said to me, you know, at first I was nervous about this, but now I feel so freed up by this approach. I actually feel more satisfied in my job because I'm less frustrated, because I have more options and flexibility in terms of the way that I can work with people. So, you know, in a nutshell, that's the spectrum of the approach that we use. So next slide, please. And then we have harm reduction principles. And I like to say when I'm presenting these are not, you know, these underpin harm reduction, but I'm sure they resonate with any practitioner that's working out there in the social care or social services or healthcare fields, right? These principles are really important to us in terms of how we're able to effectively engage people. But we chose these because they were particularly important to the harm reduction approach. So the first one is health and dignity. We know, and I'm sure you know in your practice, that we might be one of the, you know, some of the few people that when we meet people that we're working with, treat them with respect, you know, focus on their health and dignity. When many people who use drugs are stigmatized by the rest of the community or society that they're in. So, you know, for us, harm reduction is a real onus on protecting that and really embodying it and uplifting it and uplifting people. To feel respected and not judged. And then we're centering our participants or clients within the services, right? We revolve around them. We're not asking them to revolve around us, right? We are working with them and we're involving them through participant involvement to help, you know, collaborate with us, right? It's a collaborative relationship that we foster in harm reduction to, you know, involve them in decisions. We provide all the information, the tools and the education so that they can make informed choices, but ultimately moving to the principle of autonomy, right? So they are, you know, they have the autonomy to then make decisions about how they're going to apply that to their lives and the choices they're going to make. You know, I had a colleague in San Francisco who used to say, like, when he first, you know, got involved in harm reduction, it's like people were trying to dictate to me my hierarchy of needs. And when they tried to do that to me, I was out. But as soon as I came to harm reduction, nobody was doing that to me. They were asking me what I wanted to do about my needs and explaining clearly what they could do and that I could make those choices for myself. And that's what pulled me in and got me into treatment and got me into care, you know, and ultimately he got his Hep C treated successfully through that. And then the other big principle that we focus on is socio-cultural factors. So for me, I think about this as being the whole picture. Often when people use drugs, you know, come to services, it's the drug use alone that's focused upon and all the risk connected to that. But we need to see the full picture of what's going on for somebody socially, culturally, you know, all the structural factors that impact people, from poverty to lack of access to services, to lack of access to employment and education, to racism, to homophobia, to sexism, all other forms of discrimination, right, that are impacting this person. And in many cases, actually, those factors can be the things that push people towards substance use in the first place. And when those same factors are not addressed, they keep people in problematic substance use. So as harm reductionists, you know, as practitioners, we're really considering that whole picture of not just addressing the immediate risks of the drug, you know, the drug use in front of us with our participant. We're also thinking about the bigger structural factors of how we might be addressing those and those systems that we come into contact with as providers to improve the overall picture. And then the final key one we have listed here is pragmatism and realism, right? We're recognizing that drug use is a part of the world. It's been a part of the world since the beginning of time. For many people, that has deep social and cultural connotations, right? So we're being realistic and pragmatic about that. You know, there's a recent report from the Lancet that said that the US is the leading user of narcotics in the world. And even if the US reduced its consumption by 75%, still the leading user of narcotics in the world. So realistically, we need services and interventions that are going to engage people around their substance use so that we can begin to change what we're currently seeing, which is a crisis of hundreds of thousands of people dying on an annual basis of preventable overdose, and people dying of other things like endocarditis, you know, infections because of abscesses, the pressure that puts on our healthcare system, right? So that's part of, you know, these principles underpin our work in trying to change that. Next slide, please. And then this model I'd just like to share with people, because I know when I was practicing out in the field, this was such a helpful tool to me that connects to that seeing the whole picture. And if you're interested, I won't go into all the details now, but you can look up Dr. Zimberg, who developed this model for veterans coming home from Vietnam and looking at how substance use played a role in their life from like when they were serving right back to when they reintegrated back into society. But it talks about like, there's all these different factors when we think about the consequences of somebody's risk behavior. In this case, we're thinking about drug use. We can also apply it to sex work. So we're thinking about like, what are the risks of the substance itself, right? The substance, how it's used, how it's ingested, like all those factors around the actual substance itself. But we're also thinking about the set and the setting. So the set is the person, their mindset, and in many cases also their physical set, right? How are they doing? Are they happy? Are they sad? Are they depressed? Are they also, what's their health like? I know for my folks, when I was out in the field, it's like, when was the last time you had a decent meal, right? Like those basic needs. Like I know what I'm like in terms of trying to make decisions and how my cognition is if I skip a meal. And I'm sure many on this call, right, we're working with people that persistently are not getting access to good food or, you know, regular nutritional intake. So all those things go into making up someone's set when they, you know, when you're working with them. And then there's the setting, like the physical, the social, and even the cultural environment that somebody is in, that again plays into the overall consequences, which is the center of the circle. You may also see this as a triangle in some models, right? But the center of the shape is where the consequences of someone's subuse and drug use and everything else that's going on sits in. You know, and I think it's particularly important when we're thinking about unhoused folks at the moment, right? Because COVID in particular, we've seen people go from, say, being in their encampments and then, you know, and yes, whilst we may see that as not ideal, right? They're unhoused and there's all the risks of being unhoused. But however, they're with people when they're using, and then we move them. What's happened in COVID, we've seen people move into single room occupancy spaces where they're no longer, yes, they may, on the face of it, it looks like, oh yeah, they're in a stable environment, they're housed, they're out of, you know, they're inside, but they're now alone. And they may be using alone and don't have that support network around them when they were in the encampment. So again, whenever we shift someone's setting or we take stock of the setting that someone's in, there's some really important factors we need to bear in mind when we're helping them to reduce their risks and apply harm reduction interventions. I'm trying to move the slide myself. Can you move to the next slide? Thank you. And this slide just shows you the array of harm reduction services that are out there. I won't go through every one, but you will see Housing First is listed there, right? And also you'll see safe consumption services, which also most recently have been called overdose prevention programming. We've just seen 2 sites finally, after years and years of advocacy, open up in New York. For those of you that are not aware of what these are places where people can come indoors, they're given access to sterile drug use equipment they can use in a safe space, and you know, there's people on hand if there's an overdose. They've been prevalent in Europe and in Canada and in Australia for many years. And one of the things that we know from the research is nobody's died of an overdose in any of these spaces. And they're also connected to treatment services. So when someone's ready to make a change around their use, they're then right there, they can be walked over to the treatment options that are available to them. So that's some news that we're monitoring coming out of New York, and also there's many other cities, Philadelphia. I know that Seattle have been trying to work towards this for quite a while. Rhode Island are looking at opening spaces because there's such a need right now, especially with the prevalence of fentanyl in the drug supply, to have people be able to use in a safe space to prevent overdose. Next slide. And then, you know, just important for us to think about when we're engaging people, right, is that we'd like to remind ourselves as practitioners that not all people who use drugs are living unhoused, and not all people who are living unhoused are using drugs. However, there are some important overlaps, if we move to the next slide, that it might be important for us to bear in mind as we're engaging folks who are using drugs and are unhoused. So if we move to the next slide. So when we're thinking, you know, the setting, right? If somebody is unhoused and they're using drugs, those particular factors that will impact on someone, right? Where can they use safely, right? Are they using in a hurry somewhere because they don't want to be seen? It's very stressful and unstable, and in and of itself of being housed can push people towards being vulnerable to substance use, right? Because as the next box says, they're trying to cope. You know, I know our office in Manhattan is in Midtown Manhattan, and you know, before COVID, and actually I'm seeing it now that I'm going back down there, you know, you'd see people that would be sleeping in the day who might, you know, many of the folks I've worked with, you know, they'll use a depressant or a downer in the day to sleep in the day because it's safer, because there's people around and people are less likely to steal their belongings. And then they might use a stimulant at night to stay awake because it's not safe, right? They don't want people at the night to steal their stuff or attack them or hurt them. And, you know, we've seen that happen in New York City, and I'm sure you're aware of examples where you are. So people are using drugs to kind of cope with that. They're also using drugs to numb just the stress and the pain and the cold of being outside. Right? So there's lots of reasons why people are using substances when they're unhoused or maybe using. And then, you know, there's the continued stress of loss of belongings. And I know this was particularly important for me as a mobile provider, because the folks we'd see, they persistently have lost their ID. You know, it's awful losing your stuff, you know, and they wouldn't have access to, they'd either lose their phone or they wouldn't be able to charge their phone, or they, you know, most recently, like we've seen a proliferation of telemedicine, they wouldn't have access to options for that. So it's really important for us to either know people's routines so we can find them, or that we are consistent in our routine so they can find us, right? That we stay in the same place, we're there every week or every day, whatever our routine is, that they know that, you know, and they're able to find us, or we're able to find them. And then just a nod again to hierarchy of needs. And to me, again, this speaks to that holistic picture of what's going on, right? People who are living who are unhoused are like, they're focused on survival, and so, when we begin to meet some of those needs in a different way, that then frees them up to maybe think about other changes. But initially, that's their focus, right? And we come along and we're trying to help them make big changes when we need to focus on addressing hierarchy needs. And that's why Housing First was created and why it's been so successful engaging folks who are using drugs and are unhoused. Next slide. I'm just going to plug my computer in. So the final point I want to just raise again to this like holistic nature of, coming at this work is like just thinking about social determinants of health, right? And all the different layers of that impact people. So it's really important that as providers, we acknowledge those barriers and we address them at all the different levels, right? We don't just get stuck in the immediate level, and I've even seen, opportunities for participants that I've been working with on the student service program, but then I'll help them access an advocacy group like Vocal in New York that then train them to go and advocate for housing issues and Hep C treatment access and all those things. I see a quick question, what is PWUD? That's a short, it's abbreviation for people who use drugs. You may also see PWID, which is people who inject drugs. So just a nod to that kind of holistic approach again. Next slide, and I think I'm handing it back to Sarah. Sarah, you're on mute.
Thank you. So we thought we would run through some ways, some informal partnerships that between harm reduction providers and housing providers, some strategies for them. You can go to the next slide. Yeah, so one of the initial ways to kind of begin forming partnerships with one another is being a soft handoff to each other. And this really starts with creating an environment where it's safe to disclose housing status or drug use status. As a housing provider, if you're creating an environment where it's not allowed or not okay, or people don't feel comfortable or stigmatized for using drugs, this is not an aspect that you'll be able to engage with them on and can't be a soft handoff. So it starts with you and within your own program of ensuring that people who you know and are working with feel comfortable sharing these aspects of housing and drug use status, but also recognizing that they may not feel comfortable for some time, and knowing that it's your role to earn the trust. And also recognizing that when you're looking towards the other partnership here, you may be that person's trusted person. And so recognizing that if you're a harm reduction provider linking someone with a housing program, you're the person that they may come to with questions or uncertainty or frustrations, and allowing space and room for that in these partnerships is really important. It's important to have someone in your corner as you're learning to get to know someone. And I recognize the importance of this, making a transition from street outreach into housing. When you do street outreach, it's beautiful work, and it's beautiful to get to know people in that way. And it's really low threshold, and you have the opportunity to have people's backs. But as soon as I transferred into a Housing First program, I recognized, like, I come with keys and I come with maybe a landlord and a lease, and those are intimidating, and I need to take a step back and again, adopt some of those outreach models and harm reduction approaches, and recognizing if I show up meeting someone for the first time and I have got a lease and I need the copy of their ID and I need all these signatures, that is not a way to earn trust. And it might be more important to just get to know the person and engage with them, and work towards earning trust. It's also really important to be a trustworthy partner. Being a partner that can be relied on, and being good at what you do is really key here. There's an important aspect of sharing information that should be embedded with a person's choice. I've worked with, I worked with a person in my housing program who shared with me that they went to our local syringe service program, and with that they weren't interested in signing a release to share information with them, and that it just was an aspect that they wanted to keep private to themselves. And so I had to know, as a housing provider, when they walked in the doors of this SSP, they were receiving really wonderful services and they were getting support, and I trusted that process and recognized that was not something that the person was interested in having me be a part of, and that's okay. It's also a key part of allowing some informal ways of sharing information with the person being present. That can take the form of a harm reduction provider who is you see a person coming to see you, and you, hey, let's call your housing program together and let's get an update kind of collaboration. If the person is present and permission is embedded throughout. There can also be formal releases of information that happen where you all establish a more formal partnership and can collaborate with one another, and it can take a lot of different forms in that way as well. And again, just this recognition that housing takes time. It's unfortunate. And it's incredibly frustrating, and allowing space for the frustrations along the way, and staying connected with the harm reduction program as permitted by the person is important. Sharing those updates, even if it's no news, sharing like, hey, I called the landlord like 10 times, like, those kinds of conversations, being realistic. I think overpromising can really break trust. And just understanding that at the end of the day, the affordable housing is really a significant barrier. And so allowing people to be frustrated about it is important. And it's important for these types of partnerships between harm reduction and housing providers as well. And like Emma spoke to, knowing people's places, again, with their permission of knowing and sharing these things with you. But it's really important. It's important before a person is housed. It's important when they are tenants in your housing program. I worked with a person who moved into an apartment that the building caught fire, and people fled in the middle of the night for safety, and he didn't know where to go. And having worked with him in street outreach, I remembered that there was a specific coffee shop that he frequented, and it was a safe place for him. And so I thought, let me go check there. And that's where he was. And he was terrified. And we were able to link in with the Red Cross, and he was able to access a hotel, and later was housed pretty quickly thereafter. But it was just a lesson of remembering, like, if you have these partnerships with outreach teams and with harm reduction providers, they may know these things. And it's important to lean into that and get to know people in your housing program in this way, earning their trust at the beginning, and then throughout their time working with them is really key for supporting people in your housing program. And you can go to the next slide, and we'll talk a little bit about how housing providers specifically can be partners to harm reduction providers, and then vice versa. So housing providers talking about Narcan, spreading the word about it, engaging with people who are tenants in your housing program. Do they have Narcan? Do they know how to use it? Do they know how to get it, how to access it? Do you know how to access Narcan in your community? Do you know who is distributing Narcan and safe supplies? And doing these kind of partnership development throughout, and not just kind of waiting until it's needed, but really embedding it into, there's a housing program in Buffalo that when new staff start, one of their first orientation is to reach out to the syringe service program in the city and do a tour. And please call beforehand. I think everyone appreciates a heads up if you're going to come and drop in. And so, yeah, and so just getting to know who the staff are, who does this work in your community. And then really, housing providers, like, we need to be practicing harm reduction. We need to understand the principles, and we need to embed them into our policies, our program procedures, our training, and really adopt it in the way that it's meant to be embedded into Housing First. It's critical that harm reduction is part of the Housing First programs that we're a part of. And then for harm reduction providers, it's important to embed practical safety planning into your engagement with people, and just recognizing that the way they use drugs is influenced by their housing status and impacted. And Emma spoke really beautifully to some of the ways that happens. And I know grants are few and far between, and it's difficult to obtain, life-saving items that we need, like Narcan. But it's also, if you have opportunities of collecting items that people want to donate, hygiene products, socks are huge, and undergarments, sharing mirrors with people and recognizing that they may not have a safe place, to regroup during their day, and you have the opportunity to be that safe place, offering extra time in the bathroom, and just allowing them to regroup. And I know there are a lot of mobile providers on the line, and it's a beautiful way to meet people where they are. And so this may look a little differently. It might be that you'll pick up some coffee along the way, and maybe there's someone in your community that wants to support you through a grant to do that. And so just recognizing that you might be that person's safe place during the day. And then it's important to join each other's coalitions and be at the table during these conversations within your potential partner community-based organizations. You can go to the next slide. So we wanted to also include some examples of some more formal partnerships that Emma and I have experienced. So you can go to the next slide. I had the opportunity and the privilege to see this Hope Gardens and Evergreen Health partnership in Buffalo. I was working in a single site supportive housing program, which meant that 20 people were living in a permanent supportive housing program where it was very low threshold, and the majority of people who were tenants in that permanent supportive housing program were actively using drugs. And there was a grant that the team had explored of providing on-site counseling, and they had partnered originally with a behavioral health organization, and a counselor would come like once a week, hang out in a room, and we kind of started to notice no one goes into that room when she's there. And like Emma said, there was that reliability piece. We all knew when she was coming, but there was some kind of gap in this linkage. And so they ended up changing gears and partnered with a harm reduction counselor out of Evergreen Health in Buffalo, Shannon, who actually does a lot of wonderful work with the National Harm Reduction Coalition. And Shannon would come again once a week, but just had this beautiful approach. She left the room instead of waiting for people to come to her. She would engage with them where they were. And so she would do cooking with people or outings and errands, and just engaging with people in such a beautiful way. And it really just spoke to how harm reduction really just allows this opportunity to get to know people and have curiosity and find what their goals are, and just really it's a beautiful way to support people, and it worked really well in our housing program, and it was a really critical partnership development that it was a really wonderful thing to be a part of. And I was not a part of the Evergreen Health and Outreach Team partnership, but I've spoken to people on both sides, the harm reduction team as well as the outreach team, and there's a really cool way that they established a partnership. So the outreach team just started doing scheduled weekly outreach at the local syringe service program. And again, like Emma said, they came at the same day, same time each week. People knew to expect them. They were reliable, and they were there to engage with people who had questions about housing, curiosities about housing, needing housing, and updates on housing referrals. And it was just embedded into it so beautifully that anytime a model that outlasts staff turnover, you know it's pretty formal and systematized in a way that it makes a huge impact. And so I think Emma on the next slide is going to speak to a partnership she was a part of.
Yeah, just really briefly, we were able to partner with the Jericho supportive housing program in New York that we're really looking at how to deepen their housing first practices and their understanding of harm reduction across the whole staff team, because they, I think, this stuff is easier said than done, right? Let's be honest, but they started out not being housing first and they moved into it. So they were trying to be really intentional. And one of the things they ended up doing to try and, again, systematize some of this harm reduction work is that they partnered with us for training, and then also, got connected to the health department that approves people to be an opioid overdose prevention program themselves, rather than they partnered with the local harm reduction program, but they also wanted to have their own on-site overdose prevention programming so that they could give out naloxone or Narcan, as it's also called, to their staff, but also their participants, because they were seeing overdose going up. So yeah, so that's just a quick example of a housing provider really deepening their harm reduction and housing first practice. And then, yeah, the process of becoming that, it varies by state. In New York State, it's through the Department of Health, and they have instructions and a registration and an approval process that's not too onerous. So I don't know what it looks like in Massachusetts, but that might be something for people to explore, or to maybe speak to your local harm reduction program, because they may also know, as you're building those relationships and partnerships, if that's an option for you as a housing support provider. Sarah, I think, is that it?
Yeah, if you go to the next slide. Yeah, so we just wanted to leave you all with this kind of breadcrumb of who might be doing the work in your community that you want to explore partnering with. And what does that partnership look like in your community? We've given some, concrete examples of the communities that we've worked in, but those are just seeds to plant. And this is, lots of potential for the future. And if you go to the next slide, we included some links to some resources, the Harm Reduction Coalition resources. The Corporation for Supportive Housing does some really incredible trainings on providing supportive housing to people that are really wonderful. So we wanted to plug their work. And then RIZE Massachusetts, they're amazing, as we all here know. But they had this really cool Know Your Rights section on their website that I wanted to highlight. And they especially have a Know Your Rights in housing, like what recovery housing looks like and what rights you have. Also what tenant rights have of what a formal eviction looks like, and how to spot predatory housing practices and who to tell. And then Pathways to Housing, they really champion the model, they develop the model. And so they offer a lot of wonderful training and resources on their website as well, that's linked here. And I believe that is all I had. Emma, do you have anything more you want to add either? Okay.
No, I'm good. I think we had a couple of questions come in. I know, Sarah, you were interested in answering one of them. And if we don't have time, we have a record of all this so that we can bring some of these questions into future sessions as well.
Yeah, do we have time to answer any questions, or?
Sure, you can answer a question.
Okay, so there was one question of from a attendee that asks about draws attention to, and awareness to the mass and cast situation happening in Boston, and what other cities have successfully changed the tide, and what those strategies are that worked. And I just wanted to share a really incredible partnership that's happening in Ithaca, New York, in upstate New York. And it involved the coalition joining. So they formed a coalition between harm reduction and housing providers. And really it took investment from the city. The city of Ithaca provided grants and provided land for people who are living unhoused to live. And through grants, they've been able to embed supportive services to really invest in people's rights, who are people who are living unhoused in their rights. And so they have a harm reduction organization that comes and distributes Narcan and does harm reduction engagement. They have housing providers that come and engage with people around housing and link people to housing. They have a shelter that comes and engages with people and offers that as an option. But they also do they did vaccine distribution and COVID testing throughout COVID. And really it's taken everyone at the table and the formalization of this partnership through coalition building to really invest in people's safety when they're living unhoused and provide them with options and choices for their needs, for going forward. And there's some really interesting, it's been in the news. So if you look it up with Ithaca, there is some coverage on how they did it and what types of grants it took. But overall, it just took this compassion and understanding. Yeah, I see in the chat, the team at REACH is really incredible. And Ithaca does really, this has been a really cool partnership to learn about and see how they did it. So, yeah.
Awesome. Well, thank you so much. And hi, everyone. So for those of you who don't know me, I'm Craig Regis, and I'm Program Manager at the Kraft Center for Community Health at Mass General. And on behalf of the Kraft Center and RIZE, I want to again extend a huge thank you to Sarah and Emma and the National Harm Reduction Coalition for leading this important conversation, as well as to everyone who took the time out of their day to participate. And as Julie said, today's only the beginning of the conversation, and we want your input on where to go from here and how we can affect change locally. So as you X out of this Zoom session, you'll be receiving a survey to provide feedback. So please take a couple minutes just to fill that out, to send your thoughts and share what would be helpful as we move forward in the future. And as always, you can reach out to the staff at either the Kraft Center or RIZE directly to provide feedback or other ideas. We will be making the slides and a recording of the webinar available to participants, and we encourage you to share it widely. And yeah, so once again, we just want to thank you again for participating and hope that you will join us for upcoming events in the future as we continue this important conversation. Thank you so much, everyone.